We have a very interesting informational hearing today titled Challenges and Opportunities, Homelessness in California's Local Communities. Clearly, among the most complex issues that policymakers have to deal with. So many overlapping and intersecting forces have produced now a chronic homeless population in every county throughout California and across the country as well. No simple answers, no simple explanations, but many people are suffering and the need is great. We know that 65% of Americans are living paycheck to paycheck. So if a paycheck is interrupted, very soon one can be on a path toward homelessness for no fault beyond that. Throw in medical emergencies and the high cost of medical care, the situation gets even more dire. Median incomes have dropped by 8% since year 2000, but rental prices have soared by 21%. So demand keeps growing, supply is not sufficient, and costs continue to be out of balance with what workers can afford. Our federal government for the past 3-4 decades now have cut back on federal support for construction of affordable housing across the country, only exacerbating the problem. Then we have, of course, chronic mental health issues and addiction to drugs and alcohol, which also exacerbate the problem. We also have formerly incarcerated individuals who, because of felonies on their records, find it almost impossible to get anything if a minimum wage job, which one would have to have 3 of to be able to pay for an average apartment. So all of this put together leads to a very miserable situation. Of course, in San Francisco, we've been dealing with this for a number of decades. We see huge investments of public funds to just be able to stabilize a situation, but there are questions, are we actually improving the overall situation? We'll be talking about all sorts of different models. Among a very successful model in the state of Utah, and our colleague Senator Holly Mitchell has just returned from a visit to Utah and will, I believe, be here to share some of her personal experiences. And then we'll be very pleased to hear from the President Pro Tem, Kevin DeLeon, and former Pro Tem, Darrell Steinberg, to talk about our Senate proposal to be able to leverage some of the Prop 63 mental health funds to invest in affordable housing. So with that, any comments? Mr. Vice Chair.
Well, Mr. Chairman, very briefly, we will, in the course of the hearing, have our understanding expanded about some of the underlying causative factors. But our goal is not just to understand those factors. Our goal is to define solutions. And solutions are long-term. And part of the long-term is not just to provide shelter and sustenance for those who are homeless, but to provide those individuals with independence and the ability to manage for themselves in society. That would be the ultimate goal. We look forward to working with you in the long run to make those ends meet.
Thank you, Senator. So we're going to invite our first panel up, and that would include Cynthia Nagendra, who's the director for the Center for Capacity Building, National Alliance to End Homelessness. Please join us. Also, we have Dr. Margot Kuchel, who is the professor, School of Medicine at UCSF, and she has with her today 2 of her students, Marina Rosenberg and John Landfeld. We welcome them. We also want to invite Emily Halcon, who's the Homeless Services Coordinator for the Office of the City Manager here in Sacramento. And then also we'd like to invite George Ehrlich to join us, who is going to give us a personal perspective from his own experiences. Mr. Ehrlich, we're very pleased that you would take time to be with us today. Yes, Senator Wolk.
Given the schedule today, I'm sorry to interrupt, but I would like to just acknowledge one of the speakers that is coming later, and that is Supervisor Oscar Villegas, one of my constituents from Yolo County. Very pleased to have you here. Thank you for coming. Thank you.
Thank you, Senator Wilk. And I know the senators will be coming and going, which is the nature of a Thursday afternoon hearing, but we are focused on you. You have a lot of information, a lot of experience and expertise we want to take advantage of. So again, we thank you very much for taking your time to be with us today. And Director Nagendra, if we could begin with you.
Thank you. Thank you, Senator Leno, and thank you to the Committee on Budget and Fiscal Review for inviting me to speak here today. On behalf of the National Alliance to End Homelessness, I'm very honored to be here with you today to discuss how California can make true progress on the issue of homelessness across the state. I was also a resident of San Francisco for 10 years, so I'm very happy to be back in California, and I was working in homeless services around the Bay Area, so I am familiar with some of California's issues and populations. The Alliance is a leading voice on this issue of homelessness, and we use data and research to inform policy and capacity building to inform solutions around the country. And at the Alliance, we know that a great deal of hard work and strategic thinking have been going on here in many localities across the state about what to do about homelessness, and we want to commend and thank these communities in California for working to end this complex problem. California has more homeless people than any other state in the nation, and a very high percentage of them are unsheltered. Homelessness is an issue that has proven solutions that can end people's homelessness quickly and effectively, and the state does have a key role to play in implementing these solutions and ensuring that these vulnerable Californians have homes and the support that they need to stay in those homes. The state Senate's leadership on this critical issue is very critical and very much appreciated. We know the lives it will save and the families it will make whole, and we know the taxpayer dollars that will be freed up, and we know the health it will bring back to California's communities. So today I'm going to talk to you about the national trends in homelessness, where California stands in regard to other states in terms of homelessness, and really focus on solutions that we know work. What is working in California and other parts of the country to reduce and end homelessness. And we know what those solutions are needed to end homelessness, and we can see this evidenced by research, by data, and what other communities and states are doing. So first, where do we stand on homeless nationally? Homelessness is a common phenomenon in the nation, as it is here in California, and our most recent numbers are from 2015. Nationally, 565,000 people are homeless on a given night at a single point in time, and nearly a third of them are unsheltered. This number has gone down 11% since the onset of the Great Recession. So why has homelessness been going down nationally? Fundamentally, we've gotten smarter about how to help people experiencing homelessness. We've focused on investing in proven and permanent solutions, using data better, and we've figured out how to get people back into housing faster. And as we've been more successful, we have attracted more federal investment. So unlike most social issues, as the problem of homelessness has gotten smaller, the federal money for homelessness has actually gotten bigger. And the government has invested in these strategies because they're actually working. So the homeless population nationally looks like 62% are individuals, which are mostly men, 37% are people in families, about 9% are veterans, and 15% are chronically homeless individuals, and about less than 3% are chronically homeless families. The most dramatic decreases we have seen around the country have been among veterans and chronically homeless people. Each has declined nearly a third since 2007. So sizable federal investments in those populations are really the reasons for those major declines. So how does California compare to other states and to the national trends? From 2014 to 2015, there was an overall homelessness decrease nationally by about 1.2%, but increased in California by about 3.2%. Family homelessness decreased nationally by about 4.6% and did decrease in California by about 2.6%. And veteran homelessness decreased nationally at about 4% and decreased more in California, over 6%. So California does have the largest homeless population in the nation. 21% of the nation's homeless people live in California, about 115,000 people, and 12% of the nation's overall population live in California, which means that even though California is a very populous state, it does have a disproportionately high rate of homelessness. So in terms of your rate of homelessness in California, you are the 7th highest in the nation and about 40% higher than the national rate. So among the subpopulations of homeless people, you have the most unsheltered people. Over 73,000 people in California are unsheltered. And California does have, so because California has such a big population, making a dent here would really make a dent nationally. And while California is investing in some very smart solutions, many communities are still relying on temporary solutions, such as criminalization of homelessness and other sort of temporary strategies, which are ineffective, very costly, sometimes inhumane. And there are more effective solutions to fund. And the No Place Like Home initiative really does offer some comprehensive solutions. So now I'm going to just focus mostly on the solutions that we know that work. From careful research, the experience of leading communities, such as Utah, and a growing pool of national data, the key elements of a successful approach are very clear. The approach to homelessness has fundamentally shifted over the past couple of decades. Efforts of the past 20 years were marked by individual programs working to manage the problem of homelessness, but what we've really moved to is solving the problem and dramatically reducing the number of people who experience homelessness through these solutions. And we know this approach works. It reduces homelessness efficiently at a reasonable cost. We've seen it work in many communities this way. It substantially improves the lives of people once they are housed and the quality of the communities where they live. And perhaps most surprisingly, this outcomes-focused approach often brings net savings to taxpayers because the interventions are less expensive and then the cycle of emergency services that can be the daily existence of homeless people, going from emergency rooms to shelters to jails. So the most important elements of this approach that I will discuss today are, one, using a housing-first approach, and two, having a strategic, systemic response that involves partnership at all levels, city, county, state, and federal. I want to also note that these approaches are in the Lead Me Home initiative as well. Notwithstanding that homeless people have lots of issues and have service needs, homelessness is first and foremost a housing crisis. So our main recommendation is to invest in the solutions that work to house people quickly and permanently. We've been learning a lot over the years about smarter ways to help end homelessness, and that is to take a housing-first approach. Communities with the best results have an intense focus on housing people as quickly as possible. The housing-first approach, helping a homeless person move into housing and then providing other help once the person is housed, has proven to get the best results. Doubts about whether homeless people are ready for housing have been unfounded, and when the right package of follow-up services is available, and in a surprising number of instances, that package is neither extensive or expensive. So over the past decade, communities across the country have firmly established that housing first does work. None of us can really take on our serious personal or family problems if we don't have a stable place to live. Before being able to focus on the other issues that may have contributed to your circumstances, you need food and a place to live. If you don't have them, your body and mind will really continue to focus on getting them. So you won't really be able to pay attention to getting a job, budgeting properly, attending to your health needs without those less critical issues until you really get your primary needs met. So Housing First is based on this idea, and giving people a lot of services while they are homeless or expecting them to get themselves together while they're homeless is simply not very effective. So what works better is to give them housing first and then the services. So what does that mean operationally? What solutions have we used Housing First in? We would recommend two particularly important models that use this approach: permanent supportive housing and rapid rehousing. And I'll tell you a little bit about these interventions and how to effectively target them to the people who need them the most. For chronically homeless people, those people with disabilities who have been homeless for a long period of time, permanent supportive housing is the right solution. That is a permanent housing subsidy coupled with services that are focused on keeping those people that need that housing and connecting them with any treatment that they need after they are housed. And we know that permanent supportive housing is effective at ending homelessness for people who have multiple barriers, and there's a lot of literature that really says that well-targeted housing will save public dollars. So for people who don't need permanent supportive housing, you still need other housing strategies. So the way to think about those housing strategies is based on sort of what people's needs are. And if people can't get out of homelessness on their own, which many people can, and don't need permanent supportive housing, they should have immediate access to rapid rehousing. Rapid rehousing is another housing-first strategy that ends a person's homelessness quickly by using an inexpensive and short-term model of assistance. Here's how it works. A lot of people spend a great deal of time homeless because they have a cash flow problem. They lost their housing, they don't have the first and last month's rent, and deposits to get back into housing. So they spend a lot of time homeless. possibly at considerable cost to the taxpayer, to their own detriment, because homelessness has such a negative impact on people, and while they try to come up with several $1,000s to move back into housing. So rapid rehousing just kind of skips that long, expensive homeless process. Rapid rehousing programs work with landlords to encourage them to rent to homeless people and negotiate leases, provide short-term rental subsidies, often the security deposit and the first few months of rent, and follow up with supports and services, improving access to employment and other supports so the person can actually stay in that housing once the subsidy ends. These shorter subsidies through rapid rehousing work very well. The data shows us that around the country, these programs succeed in quickly housing homeless people and keeping them housed, and that the substantial majority do not return to homelessness. And rapid rehousing, actually one of the early models, comes from Utah, and that's the model that they've been relying on heavily for a long time. We also see that rapid rehousing is most cost-effective, and it works better than other crisis interventions like long shelter stays and transitional housing. California's CalWORks supportive housing program, which is funding rapid rehousing across the state, is an excellent example of using creative funding sources like TANF to bring rapid rehousing to scale. And this program has proven to be highly successful in California in moving CalWORks families off the streets and into safe, decent, affordable places to live, because homeless adults encounter great barriers to securing and maintaining employment and family stability, and because children experiencing homelessness suffer significant developmental delays. Assisting these families with transitions to a home is a wise state investment. So when these housing first interventions are allocated properly and efficiently, there are reductions to homelessness. Many communities have seen reductions. For example, the state of Virginia shifted its family system from the shelter transitional housing configuration to a rapid rehousing and permanent supportive housing configuration. They changed the state funding, trained everyone in the state on these interventions, and as a result, they reduced family homelessness in 1 year by 10%, and over 3 years, they reduced it across the state by 25%, and this is from 2010 to 2013. And I should also mention that the state of Virginia's governor and departments of housing kind of led this charge. They created a coordinating council that was led by the governor and coordinated a statewide response to implement those strategies. And then through other states like Utah, Seattle, and California have seen reductions in localities through these interventions. So finally, I want to emphasize that to make progress, the state really needs to play a role in the approach I just described and in allocating these resources effectively and investing smartly. There needs to be coordination between the state and the local entities, and there should be a decision-making body. The homeless system can't end homelessness by itself. State and local employment, healthcare, behavioral healthcare, corrections, child welfare, and housing, among others, also have key roles to play. All of that needs to be brought together and approached strategically. The state of California has an amazing opportunity right now in the Medicaid waiver as the first state in the nation to do this, so we are really excited about that. It's really providing an example for the rest of the nation in how to use that Medicaid waiver for services. And so the three things we really see working, housing first, the strategic response, and using these resources effectively, are things that we know really can end homelessness in California. And so in this state, it doesn't really make sense to let thousands of people be homeless. It's wrong, it offends our sense of basic human rights, and it turns out to cost us a lot of money. So the No Place Like Home initiative offers a comprehensive approach in many of these areas. Each component would invest in some of these evidence-based solutions. The initiative really sparks state and local partnerships, and it really shows us that we can end homelessness because we know how to do it. We just need to decide to do it here. And I want to thank you and the committee and the California legislature for your determined work to end homelessness. Thank you.
Thank you, Director Nagendra. All very interesting and sparked 1,000 questions immediately. I'm going to strain myself and ask my colleagues to do the same so we can get through the entire panel, and then we'll have that many more questions to throw at you at that point. So if you could be patient with us as we're trying to be patient with ourselves. Dr. Kuchel, welcome.
Thank you. Thank you, Chair Leno and other members of the Budget and Fiscal Committee. Thank you for inviting me to come and speak with you today. My name is Dr. Margot Kuchel, and I'm a professor of medicine at the University of California, San Francisco, and a longtime practicing general internist at what we now call the Zuckerberg San Francisco General Hospital, the public hospital of the city and county of San Francisco. I'm an NIH-funded health services researcher with substantial experience researching homelessness and health. And I come before you today to share what I've learned learned as a researcher and practicing clinician about the interrelationship between homelessness, health, and healthcare, and to speak to the costs of homelessness, both financial and human. I'm currently the principal investigator on 3 grants from the National Institute on Aging that is studying homelessness among older adults, those aged 50 and older, which is a growing proportion of the homeless population. Over half of single adults who are currently homeless are now 50 and older. This compares to 11% in the early 1990s. The aging of the homeless population adds urgency to the homelessness crisis. As a greater number of older adults experience homelessness, the costs of homelessness, already high, will only grow. The financial and human costs are enormous. Homelessness, health, and healthcare are intertwined. Poor health, both physical and mental, contributes to homelessness, and as you know, being homeless contributes to poor health. Homelessness worsens substance use disorders and makes obtaining treatment for physical and mental health and substance use disorders difficult to impossible. Homelessness presents barriers to longitudinal ambulatory care that could effectively manage these complex diseases. Faced with these barriers, people who are homeless rely instead on episodic care, both in emergency departments and inpatient settings, that are not only costly, but also less effective at achieving positive outcomes. As I will explain, older homeless people are at risk of being placed prematurely in long-term skilled nursing care, an extremely expensive form of care. The use of these services, ambulances, emergency departments, and inpatient hospitalizations are avoidable and premature risk of skilled nursing facilities contribute to the high cost of homelessness, as does use of the criminal justice system. Our research suggests that the criminal justice costs, like acute healthcare costs, are related to the intersection of health and homelessness. In many cases, individuals are jailed for behavior that stems from untreated mental health and substance use problems, or from behaviors attributable to cognitive impairment, age-related declines in brain function. Others are jailed for behavior directly related to their homelessness itself. These services, acute healthcare services, criminal justice system services, add costs without providing measurable gains in quality of life, health, or public safety. If we don't address homelessness, we are making a decision to spend large amounts of money on care that neither decreases suffering nor improves outcomes. My research and the research of others shows that individuals who are homeless use healthcare services and other public services at rates far higher than the general population or those who are poor but housed. Individuals who are homeless are 4 times more likely to use the emergency department in a year than their housed counterparts. They're several times more likely to be hospitalized, and once hospitalized, stay longer for the same problems. In older adults, these patterns are more extreme. I'm currently studying a cohort of 350 older adults in Oakland. We recruited them when they were homeless and at least 50, and we strove to make the cohort representative of all who experience homelessness in older ages. As an example, in the 6 months, so not a year, but in 6 months prior to enrollment in our study, approximately half of our participants had visited an area emergency department at least once, 28% had visited at least twice, and many far more than that. 10% of the participants had been hospitalized in the prior 6 months. This despite the fact that 70% had an identified primary care clinic and 50% had an identified primary care provider. As a longtime and proud primary care physician, I can tell you that even the best primary care is no match for the challenges of homelessness. It is a small group of homeless people, between 8 and 10%, who experience homelessness, who account for the greatest costs. For example, one individual in our study had 32 confirmed emergency department visits in the prior 180 days. This was interspersed with visits to jail and inpatient hospital stays. These individuals are sometimes referred to as frequent utilizers and account for upwards of half of all the public costs of the homeless population. Frequent utilizers invariably are chronically homeless, meaning they've been homeless for more than a year and have a disabling condition. Most suffer from co-occurring mental health and substance use disorders and have significant physical health problems. Studies, including mine, have found that homeless individuals with severe mental health problems are the most likely to be frequent users and have public costs well over $100,000 a year and upwards of $1 million a year. Older adults who experience homelessness have additional risks. In a study my team wrote that we will publish tomorrow, we found that individuals who are in their 50s and 60s have health conditions worse than those in the general community in their 70s and 80s. These problems, including cognitive impairment, difficulty with memory or following directions, functional impairments such as challenges using the toilet without assistance and difficulty getting dressed, difficulty seeing and hearing, high rates of falls, create serious threats to health and place older individuals at risk of prematurely being placed in skilled nursing facilities, one of the most expensive forms of care that we have. In our study, even though the majority were 50s to 60s, only 12% were over 65, over a quarter had significant cognitive deficits on testing, and more than a quarter had difficulty walking. As we follow our participants, we find more and more are being placed in skilled nursing facilities. For those with homes, there are many things that we can and do to forestall nursing home care. We do this in part because people prefer to live in the community, but also because care in the community is less expensive than care in nursing homes. Our findings suggest a new and looming problem, large numbers of homeless people in their 50s and 60s being placed in skilled nursing facilities when they could have been cared for in the community. So what can be done? We have an effective solution for chronic homelessness, as you've just heard about, a solution that is shown to house those who have chronic homelessness and severe comorbidities, including severe mental health, substance use, and physical health problems. Housing First permanent supportive housing or subsidized housing with on-site or closely linked supportive services and a low barrier to entry has been found time and time again to successfully house people, even those with the most intractable comorbidities. For this reason, Housing First permanent supportive housing has been adopted nationally as an intervention of choice for those with chronic homelessness. A recent small study in San Francisco showed that Housing First permanent supportive housing was able to be used in lieu of nursing home placement for a small group of older adults who had been placed previously in nursing homes. It did this safely with dramatically lower costs. There's ample evidence for the effectiveness of Housing First permanent supportive housing at housing those in needs, but the needs for it far outstrips the supply. 18 months into our study in Oakland, half of our participants remained homeless, increasingly frail and desperate, most of those sleeping unsheltered every night. Those born in the second half of the baby boom from 1955 to 1964 have had an elevated risk of homelessness throughout their lives. One of the questions that our study set out to answer was whether the older homeless individuals had been homeless throughout their adult lives or were they becoming homeless late in lives. We found that a shocking 43% had never been homeless until they were in their 50s. They did not generally fit the profile of the chronically homeless. They had worked throughout their lives until a setback, health, the death of a loved one, a loss of a job, led them to homelessness because their income was unable to pay for the rising costs of housing. We have found that these individuals are highly likely to remain homeless for over a year. We see their health plummet and their homelessness becomes entrenched, leaving them with severe health problems and few resources to manage them. While they did not fit the profile of the chronically homeless at the outset when they lost their housing, they quickly become chronically homeless with similar costs and consequences. Before closing, I'd just like to leave you with a story of one of our participants who has allowed me to share it, to put a human face on this problem. Dwayne, who shared a story with a journalist, which was in an article that was recently published, is 68 and lives in his car. He has HIV disease. About a year ago, he started to cough and, unable to get to clinic, went to the emergency department and was admitted to the hospital. In the hospital, he was diagnosed with lung cancer. While he was referred to an oncologist for consideration of treatment for palliation or treatment of his lung cancer, because of the impossibility of administering chemotherapy to someone who lives in his car, never received any treatment, curative or palliative, for his lung cancer. Getting to appointments was very difficult. His condition worsened, he lost an enormous amount of weight, had difficulty breathing, and was in unbearable pain. He had been prescribed some pain medication but couldn't find them amongst all of his possessions neatly held in the back of his car. He expressed fears. In severe pain with difficulty breathing or walking, he said, "I just don't want to die here in my car." 2 weeks ago, as the story was going to press, his friends found him nearly unresponsive and took him to the hospital, where he has since been in the intensive care unit. I want to point out the irony here, because stays in the intensive care unit cost upwards of $1,000 a day, and an ICU stay at this point will not provide him with the possibility of managing his lung cancer, relief from his suffering, lessening of his pain, fear, despair that he has experienced over the past year. This is one of many poignant examples of a missed opportunity to have provided a member of our community compassionate and cost-effective care. There are hundreds, if not thousands, of Dwaynes on the streets of California. Inaction on homelessness will not reduce costs or relieve their suffering. So as a researcher, clinician, and fellow Californian, I urge you to consider the costs, both financial and human, of inaction on homelessness. Thank you.
Thank you, Dr. Kuchel, for the presentation and for all your good work.